can we as clinicians try to make bispecific antibodies better? We are now looking at clinical trials to move these bispecific antibodies which are now approved in the 5th line setting to earlier lines. Like, can we do them in early relapse, like 2nd line, 3rd line, 4th line, for a better action? Because the whole rationale is that we are trying to see if we can utilize the body's immune system when it's a little bit more stronger, rather than at the 5th line or later when the immune system is all tired out after getting all these chemotherapy and also after trying to take care of the cancer for so long. We are studying this in combination with other drugs. There is the Majestic 2 study, which is looking at teclistamab and daratumumab and lenalidomide. The Majestic 3 study, which is the teclistamab and daratumumab versus standard of care like dara-PD or dara-Velcade-dex. And also, we are trying to combine with another bispecific antibody. There's a redirect trial in which teclistamab and talquetamab were combined together. And in a very few number of patients, we saw excellent responses in patients who had extramedullary disease. So all these are ongoing trials that we hope will answer some of the unmet need in multiple myeloma. How does the future look with these therapies? Now, I think that the way the field may turn into the future is that there will be better designs for these bispecific antibodies, which will have a higher antigen or protein binding, however, without increased toxicities. They potentially, once these Majestic 2, 3 trials and all read out, they may be brought to earlier lines of therapies. They could be, instead of being given as a monotherapy, they could be combined with other therapies like lenalidomide, immunomodulatory drugs, cell mods, etc. It potentially may be used as maintenance therapy in lieu of autologous stem cell transplantation, which is right now the standard of care. It could be used as it could be utilized as consolidation for less than adequate response to induction chemotherapy. And potentially, we are also looking at time-limited therapies guided by minimal residual disease negativity, because right now bispecific antibodies are given indefinitely until disease progression. And finally, how to sequence bispecific antibodies with CAR-T and other T-cell engaging therapies based on T-cell health and other exhaustion markers. Now, in summary, bispecific antibodies in multiple myeloma represent a completely new era in immunotherapies, with response rates in heavily pretreated myeloma ranging between 65 to 75%. Currently, there are 3 FDA-approved bispecific antibodies, 2 targeting BCMA called teclistamab and elranatamab, and 1 targeting GPRC5D called talquetamab. The current indication is after 4 lines of therapy as the 5th line, and studies are being conducted to move to earlier lines and also in combination with other drugs. The initial step-up dosing is usually in the hospital, followed by an outpatient administration model. And some of the adverse effects include cytokine release syndrome, neurotoxicity, hematologic toxicity, which is low blood counts, and increased susceptibility to infections because of hypogammaglobulinemia. And unique to talquetamab, there are skin, nail, and taste changes that we always keep track of.